And millions of people around the world have been infected with COVID-19 and hundreds of thousands have died, but not much is known about the long-term effects of this virus. 46-year-old Michael Rajales is a pastor from Melbourne's southeast.
Back in March, he was one of the first Australians to contract the virus. His mother-in-law died from the disease and Michael himself spent over 2 months in hospital. And so 6 months on, he's upbeat about his recovery, but acknowledges he still has a long way to go.
I first contracted COVID-19 on the way back from a trip in South Africa. I went into the hospital on 25th of March, and then on the 29th, I was taken into the ICU to be sedated and intubated. And I was in an induced coma for 14 days. When I woke up, my world has changed significantly. When my wife was able to visit me, and she told me what happened to me in hospital, and I had no idea. I had no idea that I stopped breathing, that they told my wife that she should prepare to say goodbye because they think, prepare for the worst prepare for the worst in the next 24 hours, basically. I learned that my mother-in-law contracted corona as well, was hospitalized and died 6 days later. And whilst all this was happening, I found out that my wife was hospitalized as well because of corona. 6 months on from when I first went into hospital, I'm still having muscle weakness and nerve damage in my left leg. At the moment, I walk with either a four-wheel frame or a pair of crutches. My left leg is still not weight-bearing. The doctor said that it would take about 18 months to 2 years before my nerve damage would be fully healed. And so we're just trying to build strength and doing what the doctors say to get better. In the case of my family, it spread from me. For myself, I brought it into the household. My wife caught it, and my mother-in-law passed away because of it. We don't want anyone going through what our family has been through, and so be careful enough not to get it, and be caring enough not to spread it.
Yeah, gosh, we still don't know as much as we would like to know about this virus, and I'd love to actually bring in the presenter of RN's Health Report and the ABC's Coronacast podcast, Dr. Norman Swan. Norman, good morning. You heard him there. This is a real worry, isn't it, that we just don't know the long-term effects?
No, we're beginning to learn about it, though. There's a study going on out of the St Vincent's Hospital in Sydney trying to follow through people who've had COVID-19 disease. The two worrying areas, so it does affect the blood vessels and affects the blood vessels quite profoundly, and it does infect heart tissue. And people are worried, for example, that there could be long-term incidents in quite young people of heart failure as a result of this, because the actual muscle, the surroundings and the heart muscles themselves are infected. And then there's the nervous system, which is what you heard there. So the virus almost certainly gets into the nervous system and affects parts of the brain, probably through the nose. So the nose is where the virus comes in, but at the top of the nose, you've got basically where you smell through is an outcrop of the brain. So it almost certainly goes in through there and also gets inflammation of the blood vessels. This is a serious disease which we will be living with the effects of for a long time to come, and not to be minimized. And younger people with lesser symptoms are also feeling the effects as well.
Now, very keen to get your views on this frenzy debate, Norman, about how tough or how lenient or otherwise is this new Victorian roadmap. What do you think about what Daniel Andrews is proposing here? The aim, if you just clear away all the debate, the aim has to be to get as little virus circulating in Victoria as is possible. And the cutoff that you choose is a bit arbitrary. It's not plucking it out of nowhere. They've obviously done modelling, but it is a bit arbitrary. That's the aim, to get as little as virus circulating as possible, so you know where it all is, and that you match that level with the level of ability of people coming forward for testing and then contact tracing. And that's what you've got to modulate. And so when they've done the modelling, and then you've got to work out just will people still socially distance. If people are socially distancing and really going along with that as you come out and staying with that behaviour, then you can actually cope with probably a slightly larger number of cases. But the risk is that you're sitting on a powder keg that could blow up. I mean, Britain started to relax at, 200 or 300 cases a day, and they're now at 1,800 cases a day. Israel, relaxed too early as well. Singapore had the outbreak there, and they relaxed. I think in non-migrant areas of Singapore, I think they relaxed at about 5 to 10 cases a day, something like that. Korea's got a big problem with that church group now, but they've been managing with a steady state of about 200 cases a day. You just got to be able to, but they've got a lot of infrastructure there. People are coping with apps on their phone, geolocation that we probably wouldn't tolerate. So it's the infrastructure that goes around it.
And what about this idea that New South Wales is the gold standard of how it's dealt with it all?
New South Wales isn't the gold standard. New South Wales is lucky. New South Wales got down to low levels of circulating virus, and 1 or 2 cases came in from Victoria and spread. And yes, it's been a problem, and they've managed to get on top of it. But when you've only got a few cases, then you can actually deploy your contact tracing system more effectively. I think it is true though that in New South Wales and Queensland, they've got a much more ground-based public health system than in Victoria. Just remember, in 2009, I know Victorians hate when I start saying this, in 2009, during the flu pandemic, Victoria stopped testing. They stopped testing because their public health system couldn't cope with it. And not a lot was invested after that in the Victorian system. So they're playing catch up. And when you hear these comments, now Brendan Murphy knows the Victorian system deeply, as does Alison McMillan, who works at the Commonwealth level. There's a lot of deep knowledge about the Victorian system. And I think what you're seeing is nervousness that even though you've got 2,500 people who are working, their hearts out, they feel responsible for it. This is not their fault. But I think they're working at a system that's playing catch up that's surrounding them.
Now, you heard Lisa's interview with the CSL Chief Scientist, Norman, before coming on. What do you make of, on face value, a great move, CSL undertaking to manufacture any vaccine?
I think that we should be getting native manufacturing going to Australia. It's a really good decision. It means that we are relatively independent of overseas supplies. And if the Oxford vaccine doesn't work out, I mean, it's looking pretty good. You've got the Queensland one in backup, but that's going to be a few months behind. You've also got the Moderna vaccine, the mRNA vaccine, which I think is going to be produced in India. So there should be quite a fair supply of that, which you could buy in. I think we should be okay. There's only so much money you can spend in shoring up your bets here.
Yeah. Hey, Norman, thank you very much for joining us this morning.
Always a pleasure, Lisa. Bye, Michael.
Thank you, Norman.